Good morning. Today we are going to deal with the topic patent ductus arteriosus. What do you mean by patent ductus arteriosus? Ductus arteriosus is a normal structure in the fetal circulation. When it is present even after the delivery of the baby is called patent ductus arteriosus. It is the failure, it is termed as, coming to the definition, it is termed as a failure of fetal ductus arteriosus to close within the first week of the life is called patent ductus arteriosus. The ductus arteriosus is a normal fetal structure that present in between the pulmonary artery and descending aorta. It is normally present in between the pulmonary artery and descending aorta. In the normal fetal circulation, the blood flows from the pulmonary artery to the descending aorta in the pulmonary circulation. There is no presence of lung involvement in the fetal circulation due to the collapsed lungs, but after the delivery the lung will be activated and the circulation will be in a normal manner without the usage of the ductus arteriosus. But in PDA there is a presence of the patent ductus between the aorta and the pulmonary artery. So there is a abnormal flow of blood from the high pressured blood in the aorta to the pulmonary artery, which have a low pressure blood. This is account for 5 to 12% of the total congenital disease, and it is an isolated disease in a normal baby. Patent ductus arteriosus is commonly seen as an isolated disease, but it can be seen as a combined with or associated with other congenital disease like Klinefelter syndrome or other congenital heart diseases. In PDA, the blood flows from the aorta, that is high pressure area, to the low pressure area, that is pulmonary artery, and there is a high volume burden for the lungs. So when there is a flow of blood from the pulmonary artery to the aorta, it causes increased blood flow to the lungs, that is burden for the lungs, and ultimately results in the left side of the heart. Females are more affected than the males in the ratio of 2:1, and is a most cardiac lesion associated with congenital rubella syndrome and Klinefelter syndrome, Rebstein-Taybi syndrome, and this is more common in babies born at high altitude. It is very common in babies that is born at high altitude. Next we have to move on to the types of PDA. PDA can be small, moderate or large. Small is decrease less than 4 mm size at the aortic end. When the ductus arteriosus size is less than 4 mm size at the aortic end, it is called a small PDA, which is almostly asymptomatic, and pulse volume is high. In this, the pulse volume is high, the BP may be mildly increased. Pulse volume means it is a difference between the systolic BP and diastolic BP, that is pulse volume. Pulse volume may be increased and BP may be increased. The murmur is continuous murmur because the entire cardiac cycle, during the entire cardiac cycle, in the systole and the diastole, the blood will be flows from pulmonary artery to the aorta takes place, so that the murmur is continuous. That's why murmur is continuous. Murmur is continuously heard at the left upper sternal border. Next is the moderate or large type of PDA. Moderate to large type of PDA have a size of greater than 4 mm size at the aortic end, which is usually symptomatic, and mild growth failure or congestive heart failure may be present. Symptomatic, that is mild growth failure or congestive cardiac failure may be present. Next is high volume collapsing pressure and wide pulse pressure may be present. I already said that there is a widened pulse pressure at the small PDA, and the widened pulse pressure, the width of the pulse pressure is very large in the moderate or large PDA, and high volume collapsing pulse will be present. In types, there is a small PDA and moderate or large PDA. Small PDA has a less than 4 mm of size at the aortic end, and it is usually symptomatic, but they have a high pulse volume, and BP may be increased, and murmur can be continuous, and it may be heard at the left upper sternal border. And moderate or large have a size of greater than 4 mm at the aortic end, and is usually symptomatic, have a wide pulse pressure and high volume collapsing pulse, and it have a mild growth failure or congestive cardiac failure. Coming to the continuation of the moderate or large PDA, it has a cardiomegaly. In moderate or large PDA, there may be cardiac megaly may be present. Murmur is continuous. As we already said in small PDA, murmur is continuous, heard at the left upper sternal border. It is characteristically machinery like with multiple clicks and often masks S2. It often masks S2. That is, between the S1 and S2, the murmur will be present, and the doctor or the healthcare worker cannot be recognize the S2 sound during the auscultation because the murmur will mask the S2 sound. An additional mid-diastolic murmur at the apex due to large flow. At mid-diastolic murmur can be felt, and additionally, along with the murmur, mid-diastolic murmur can be present at the apex of the large apex of the heart due to large flow because its width is greater than 4 mm. Compensatory PDA. If there is a total obstruction to the systemic flow or pulmonary artery flow, there must be a ductus to maintain the flow to systemic or pulmonary circulation. Such as patency duct will provide compensation for critical obstruction like pulmonary atresia, tricuspid atresia, aortic stenosis, or coarctation. Compensatory PDA. Sometimes the PDA will be beneficial for the child's life because when the patient is presented with critical obstructions like pulmonary atresia, tricuspid atresia, aortic stenosis, or coarctation, the patency of the ductus will be the normal duct will be impaired. So the blood can be flows through this patent duct to the systemic and pulmonary circulation. So the patent duct is helpful for the pulmonary and systemic circulation in cases of the obstructive conditions like pulmonary atresia, tricuspid atresia, aortic stenosis, and coarctation. Next, we have to move on to the diagnosis. First we have to collect the history collection, physical examinations. At that time, we have to felt the continuous murmur, mid-diastolic murmur at the apex, and the continuous murmur can be felt at the left suprasternal border. In ECG, left ventricular and left atrial enlargement can be felt, and biventricular hypertrophy in the pulmonary artery hypertension. When there is a pulmonary artery hypertension, there may be seen as a biventricular. The both ventricular hypertrophy can be felt, and ECG, there is a left atrial and left ventricular enlargement can be felt. In chest X-ray, cardiomegaly can be felt with enlargement of left atrium, predominant pulmonary artery with plethora. Next is aortic knuckle is prominent. Aortic knuckle. What may be aortic knuckle? The aortic nerve or aortic knuckle refers to frontal chest X-ray appearance of the distal aortic arch as it curves posterior laterally to continue as the descending thoracic aorta. It appears as laterally projecting bulge. Next, we have to move on with the management of the PDA. All PDA beyond 3 months of the life require intervention, either surgery or catheter-based intervention, because all the PDA before the 3 months of the life, if the PDA cannot be closed within 1 week of the life, and we have to further observe for the further evaluation, and if it is not closed even after the 3 months of the life, we have to require the interventions like either surgery or catheter based interventions we have to give. In case of small PDA, we are using gain Turco coil, and using this coil the occlusion will be done. The PDA, the patent duct, the duct will be closed, the ductus arteriosus will be closed using the giant Turco coil with the coil occlusion in small PDA. Insertion of the coil is using through a retrograde approach through the aortic end. We are inserting the coil through a retrograde approach through the aortic end of the heart. And the device closure, catheter closure of ductus with different devices such as ampliature. Ampliature can be used, different devices such as ampliature can be used for the device closure or catheter closure. If we use a coil, we are using giant Turco coil. If we use a catheter, we are using devices like ampliature. Next, surgical. If the PDA is mild or small PDA, we have to use coil or catheter for the occlusion. If the PDA is large or moderate, it can be, if greater than 4 mm diameter, it can be used. We have to use the management as surgical management. Surgical management is 3 types: triple ligation, division, and suture. Suture timing is between 1 and 2 years. Triple ligation is usually for Smaller ducts. If the patent duct is smaller, we have to done with triple ligation. Next, division and suture for large PDA. For large PDA, division and suture, triple ligation for small PDA. Surgical timing is between the 1 and 2 years, 1 to 2 years. So we have to done the surgical intervention within 1 to 2 years. So till now we discuss about what do you mean by the patent ductus arteriosus, what is the normal function of the ductus arteriosus, and what is the incidence and prevalence, and when the associated conditions we are discussed about, and what is the pathophysiology we discuss about, and the types, two types, small and moderate or large, we discuss about, and how to helpful the PDA will be, how the PDA will be helpful for a child with other obstructive diseases, and we have to discuss regarding the diagnosis of the PDA, that is ECG, chest X-ray, we have to done to evaluate, and management of the PDA, that is both catheter or coil occlusion intervention and also the surgical intervention we discuss. I hope